Hello, everyone, and welcome to today's webinar, Nursing at the Crossroads, How Can Acute Care Recover from the Pandemic? Thanks so much for joining us for this critical issue. A few details before we get started. There's always housekeeping details. First, everyone's lines have been muted to avoid background noise. Secondly, this webinar is being recorded, and the link to the recording will automatically be sent via email to all registered attendees. My name is Sean Kennedy. I'm the editor-in-chief of the American Journal of Nursing, and I'll be your host today, along with AJN's senior clinical editor, Dr. Christine Moffa. This program is the 8th in AJN's webinar series examining important issues affecting nursing practice and healthcare. AJN has a long history, over 121 years, of providing content nurses need to deliver high-quality, safe care. But that means covering more than just clinical nursing topics, and it includes raising awareness of key issues that impact the health and welfare of those to whom we provide care, as well as advocating for ourselves in our profession. Today we're proud to have as collaborating partners two other award-winning Lippincott journals, Nursing Management and the Journal of Nursing Administration, or JONA. Both of their editors are participating on the panel. Today's presentation is accredited for continuing education units, and Lippincott Professional Development will award 1.5 contact hours for this program. So it's important you stay on till the end. The presentation at the end will have a slide at the end, or in the chat box actually, at the end of the webinar. You will automatically be taken to a screen to fill out a short evaluation form to receive a CE certificate. And then the PDF of instructions will be in the chat box. Please do make note of that phone number in the bottom of the current screen in case you have any problems. So here are our objectives for today. By the end of this webinar, each participant should be able to describe the ongoing challenges faced by nurses in various acute care settings as a result of the COVID-19 pandemic, and also to look at key questions and priorities that we should be addressing to move towards a post-pandemic workplace that supports, respects, and fosters the contributions of acute care nurses. So, before I get into introducing our panel, we'd like to know a little bit about who you all are. So we're going to put up a poll question in a moment. And while you're answering the poll, we realize we may not have every title or every role, but do the best you can in terms of matching what you do to the types of answers we have here. While you're making your choices, I'll give you a quick overview of today's format. Each panel member will take about 5 to 10 minutes to present, and then Christine will pose questions from the Q&A to the panel. We're hoping this will spark a robust discussion and generate questions to create a broader understanding of the very complex and intertwined issues that we'll need to face in order to move forward and create a better acute care workplace. We know some of these issues are hot button issues, and we do ask that questions and comments be respectful of others' opinions and really contribute to moving the discussion forward. After some discussion of your questions, we'll then ask the panel what questions would they have, what 1 or 2 key questions would they want to know or raise in order to be strategic in thinking about how we move forward. So if we can see the poll results, let's see what we have in terms of poll responses. All right, 21% staff nurses, a small group of advanced practice nurses, 18% nurse managers, 4% CNOs, 1% CNO and CEO, and then 16% instructors, HR, and then a non-health professionals. So the majority of staff nurses and nurse managers. So that's a good split. We can close that slide. Thank you. So now I'd like to introduce our distinguished panel. First, we have Connie Barden. Connie is the Chief Clinical Officer of the American Association of Critical Care Nurses, where she provides strategic leadership that drives the development of clinical practice resources that meet the rigor of a rapidly changing healthcare environment. And you don't get any more rapid than what we just went through with COVID. She's the executive leader of AACN's Strategic Advocacy and Voice Team. She practiced for many years as a clinical specialist in various critical care venues. Connie received her undergraduate degree from the University of North Carolina at Chapel Hill and a master's from the University of Alabama at Birmingham. She was also an AACN president from 2002 to 2003 and led the task force that framed the landmark AACN standards for establishing and sustaining healthy work environments, a journey to excellence. We also have Karen Hill. Karen recently retired after 28 years as the Chief Operating Officer and Chief Nursing Officer of Baptist Health in Lexington, Kentucky. During her tenure, Baptist Health Lexington was recognized for nursing excellence and awarded Magnet designation 4 times. Dr. Hill is editor-in-chief of the Journal of Nursing Management, of the Journal of Nursing Administration, an international scholarly journal that's circulated in over 146 countries. She presents internationally on leadership development, bringing evidence to practice, leading an intergenerational workforce, and how to retain experienced older employees. She has many peer-reviewed publications and is co-author of a book, Creating a Research-Friendly Environment, a Community Hospital Approach. We also have Rosanne Raso. Dr. Rosanne Raso is Vice President and Chief Nursing Officer for New York Presbyterian Hospital Weill Cornell Medical Center in New York City. Previously, she was nurse executive at Lenox Hill Hospital and then Chief Integration Officer for NYU New York University, that is Langone Hospital in Brooklyn. And as an experienced nurse executive for over 19 years, Dr. Raso is a national leader in improving the practice environment for staff, enhancing patient safety, and advancing nursing leadership. She's also the editor-in-chief of Nursing Management and an adjunct assistant professor for both New York University's Rory Myers College of Nursing and Case Western Reserve Francis Payne Bolton School of Nursing. Her published research is regarding authentic nurse leadership and healthy work environments. And we also have Cynda Hilton Rushton, the Anne and George L. Bunting Professor of Clinical Ethics at the Johns Hopkins Berman Institute of Bioethics and the School of Nursing, and holds a joint appointment in the School of Medicine's Department of Pediatrics. Her scholarship focuses on moral suffering of clinicians, moral resilience, and designing a culture of ethical practice. In 2016, she co-led a national collaborative State of the Science initiative on transforming moral distress into moral resilience in nursing, and co-chaired the ANA Professional Issues Panel that created a call to action exploring moral resilience towards a culture of ethical practice. She's the author and editor of Moral Resilience, Transforming Moral Suffering in Healthcare, which was the first place recipient of the AJN Book of the Year Award in Professional Issues. She's a fellow in the American Academy of Nursing and the Hastings Center, and is a member of the AJN editorial board. Thank you all for being here to contribute to this discussion. So now, before we go on to set this up a little bit, as of October 13th, which is only last week, over 713,000 US deaths have been attributed to COVID-19. And we know that there are several areas in the country that are still seeing overwhelmingly high numbers of hospital admissions and deaths, and that contingency standards of care are commonplace in many institutions. The pandemic is by no means over and may very well be here for some time. Nurses at all levels in all settings have been affected, but those in acute care have borne the harshest effects. Acute care nurses have had to deal with enormous obstacles and challenges that we all acknowledge have existed pre-pandemic and have only been exacerbated and overwhelmingly exacerbated, and have made many acute care nurses feel unsupported and unheard. We know the pandemic is going to be here for a while, so we all are very concerned about how this is going to play out. The question is, how do we move forward in this state that we're in, this shaky state of when the pandemic is going to end, when is it going to surge, how are we going to be flattened out in terms of dealing with an ongoing pandemic. In discussions with these panel members, who I count as friends over the last few months, we know that there is no easy or magic fix to these issues, but there are some key issues and questions that, depending on where one sits in the organization, what one's role is, and area of responsibility, some may be more amenable within your sphere of influence than others. And if we're going to move forward in a strategic way, we need to think about how best to do that. So right now we are at a very pivotal moment in nursing, especially in acute care, and now is the time to really reset nursing care delivery in the acute care setting. So today we're asking our distinguished panel to talk about what we need to be thinking about to restore the acute care setting as a desirable workplace where nurses are respected and listened to, whether a staff nurse, unit manager, or CNO, or a health system administrator. What might be addressed in each's own sphere of influence and responsibility, either short-term or long-term, but what can support colleagues and staff? What can we do to revisit care delivery, evaluate COVID-induced changes that might be worth carrying forward? There are a lot of things to think about, so we're hoping that with this panel, we can start thinking about those. So now I'm going to ask the panel, and they'll each have a few minutes, as I said, 5 to 10 minutes, to reflect on what they've learned and experienced from the pandemic, and what does this leave them thinking in terms of issues that they feel they should be addressing or could address within their own sphere. So Connie, would you start us off?
Sure, Sean, thank you. Hi, everyone, and welcome. We are so grateful that you carved out time to be with us today. And as I was listening to Sean and thinking about this, I realized that it really is a privilege to be asked to share from the perspective of frontline nurses. That's where my heart and soul is and where most of my practice has been. So to your point, Sean, I think we have one of the most surveyed and studied nursing workforces right now that we've ever had. So I've got my comments put into 3 buckets. The buckets are data, a quick reality check, and then a couple of issues and hope. As I said, academics, researchers, commercial entities, hospitals, health systems, everyone is studying nurses right now, probably because of concern. How are nurses doing and what are their plans? I would say that across the board, we've heard reports of anxiety, exhaustion, which physical, mental, emotional, and so forth, depression, in varied numbers since pretty early on in the start of this pandemic. But I think what's important is that more recently, and I would say probably in alignment with the 4th wave, we have heard new complaints or new reports of frustration, anger, moral outrage, resentment, feelings of betrayal. And there's been a shift in some of these emotional reports we've gotten. And it's speculated that in this 4th wave, it's largely because of stretched resources that have been taken to a breaking point, and also many people considering that the 4th wave could largely have been prevented. So it's hard not for healthcare providers not to feel some resentment in those circumstances. The other things that's been wildly studied in terms of the plans of nurses is intent to leave. And for the first time in my career, researchers are using the term flight risk in describing nurses and the possibility of leaving the workforce. Now, we don't have time to go into it, so it's varied depending on age and years of experience and geographical locations, but across the board, pretty consistently, we're hearing that up to about 30% of nurses are considering leaving their current position. Thankfully, a much lower number considering leaving the profession. But in the context that we're talking about today, acute and critical care, imagine if 20 to 30% of nurses left. It's just hard to wrap your head around. Now, I'd like to pause for a reality check. And the reason I want to do this is because I think we want to be certain to pause and think about what it is that frontline nurses really have had to deal with for an extended period of time. AACN prides itself in being the largest nursing specialty organization. We have about 130,000 members, and we really feel that we have our fingers on the pulse of acute and critical care nursing. So I want to share 2 stories with you to exemplify some of the unique things that nurses have dealt with. One comes from a nurse who was staffing an ICU that had been turned into a totally COVID unit. And she relayed to me that she would come to the unit, she would get report, and pretty standard because they were, jammed with people. She would pretty standard have 3 patients. She would get reports, she put on all the PPE, and she would go in and she said, I had to look at my patients and triage them mentally as the nearly dead, the dying, or those working on surviving. And despite what I knew physiologically I needed to do and so forth, I had to make a moral decision. I had to get down to my soul and decide where I needed to spend my time. And her choice, she said, often was with the nearly dead initially, those who had minutes to hours to live. So walking past those working on surviving who needed a blanket or glass of water to care for others. And another summary comes from an acute care nurse practitioner colleague of mine who's in the Southeast. This person is in a place that's been slammed with the initial surge way back, seems so long ago now, and also in the 4th wave. And he said, I don't think I'll ever forget the experience of intubating one of our own nurses. And then I had to intubate my friend's father. And he says on that unit in the early days of COVID, when he said we knew so little about how to treat these horribly sick people, they were keeping track of the number of deaths. And he said one day we got to death number 146 and I decided to stop counting. Because at that time their unit was at 300% occupancy and their mortality rate early on was 70%. And his quote to me was, professionally, I've never felt more needed or more useless as we have been able to save so few. I mention these graphic examples because I think it's worthwhile to pause and think what the humans called frontline nurses have had to deal with on an extreme and extended basis. And that brings us into a couple of the issues and then some hope that I want to wrap up with. So the issues, the first one I want to mention has to do with this level of emotional and moral distress that we've seen because it has been so extreme, so personal, and so prolonged. And there are those who say that we need to help people recover from this coming from a trauma mindset. For a certain number of individuals, helping them to heal in a way that those who've been exposed to trauma have been healed. So that may be an issue that we can't use some of the usual platitudes about, yeah, acute care is hard, critical care is hard. That's what we signed up for. This level of distress is not what anyone signed up for. And I think we just have to be cognizant of that. Another thing I want to mention, which I don't normally mention, is the issue of pay. And that is unique about what's going on right now. And here's what I would say, because staff has been sort of ravaged and a lot of people are leaving to travel. And so we're working with travelers and that kind of thing. There's a challenge going on now when loyal staff, say a 10-year or 20-year-old staff member stays in their institution that they love or they can't travel, whatever, they stay and they show up every day. And they're working shoulder to shoulder with someone who's temporarily staffing their unit. And we're grateful for that, but temporarily staffing their unit and doing the same work but making 3 to 5 times more for the same work. And I think if we look at our human side, it's understandable that that could cause resentment and all kinds of dynamic issues. And I just wonder, aren't there some financial models that we could put in place now for short term to help sort of balance this out, at least for the rest of the pandemic? Because where we put our dollars represents where we put our values to people. The third thing we have to mention on this panel is staffing. Certainly, we know it's not new. It's been around for decades. But I'll tell you, as I said, we pride ourselves in being in touch with what's going on in acute and critical care at AACN. And I have not talked to a nurse or a nurse leader in the past 3 to 4 months anyway, who has not mentioned a staffing crunch. And even if it's not that we don't have the exact number of nurses. Sometimes units are staffed with, say, 80% nurses who have less than a year or 2 of experience, which can have a huge impact, particularly in critical care. Or 50% travelers. And again, we're grateful travelers are there, but it does alter the dynamic there. And sometimes there just aren't enough nurses and beds have to be closed. The bottom line about staffing is the research absolutely shows that an insufficient number of nurses leads to safety and quality issues, and safety and quality issues are two of the main drivers of moral distress and intent to leave in nurses. And then the final thing I want to mention as unique that we must deal with, it was absolutely present before the pandemic, but it's back, is violence against healthcare workers. I don't have the data on it, but we're hearing that it is back to pre-pandemic levels, if not worse than ever before. And I would say, whether it's federal or state or organizational, it's time for zero tolerance policies and ways to implement those so that staff feel safe in doing what we brought them here to do. The good news is that we know a lot of things about nurses and what they want. Now is the time. Nurses have never been more visible in terms of their contribution to care. And we have some things that we know make a difference. One of my biases, just like Rosanne, and I think probably others, is if we tend to the work environment, this environment in which people want to come and do this work, it'll be a great start. And Sean mentioned the ASN standards for establishing and sustaining a healthy work environment. We've mentioned some of the tenets already, but the fundamental things like how we communicate and how we collaborate within a unit with our leaders across disciplines, critically important. Nurses having a voice at decision-making tables, being present and speaking up. This can no longer be considered non-productive time. There's nothing more productive than hearing from nurses who know how to deliver care. So if that's the model that we have, that a nurse sitting in a meeting giving a professional opinion is non-productive, I think we need to look at that model. We've got to find ways to recognize a professional contribution of everyone that goes a little bit past pizza and ice cream and some of the things that we do with great intentions. And then the final glue that holds the work environment together, of course, is authentic leaders. And I'm on a panel with some of the most stellar ones that I know that you're going to hear from in just a minute. But authentic leaders who are present, shoulder to shoulder, eyeball to eyeball with nurses, who get it, who listen, who ask questions, and then who act. So that's the hope. I think we know a lot. There are all kinds of tools for helping to assess the work environment. There's all kinds of things we do that cost nothing to get going. And I'm going to stop there, Sean, because I think Rosanne will go next, and then in a little bit, we'll have time for questions. So thank you, everyone.
Thanks so much, Connie. Great comments and perspective, I think, on the whole picture of what acute care nurses have dealt with and what can be some solutions, or at least towards working towards solutions. So thank you. Rosanne, how about from your perspective in nursing management?
You know, there is so much from everything that Connie Barden just said that aligns with the perspective of nurse managers everywhere. So first of all, when you discussed the frustration and exhaustion and even anger of the front line, well, guess what? The nurse managers are feeling that as well. And I heard Rose Sherman, who is the nurse leader editor, talk this weekend, and in her experience with nurse managers and various courses that she gives, she heard loud and clear that nurse managers feel like they are whitewater rafting every day. And you can actually picture that. Imagine yourself in a raft in white water, just trying to not go overboard and drown. And that is what our nurse managers are dealing with. So they're dealing with the same kind of personal feelings of exhaustion and anger, and how healthcare and vaccinations got politicized, and that these last waves have been totally preventable. So they have all of those feelings, as well as having to really manage the burnout that the staff are feeling. It's up to that unit manager, and I'm as a chief nurse, I'm dealing with it as well, is trying to help everybody through that. It's a big burden. And I don't mean to say a burden in a bad way. This is what we do as leaders, but it's really hard. On top of all of that, nurse managers are dealing with all these staffing issues, which are humongous. They are dealing with volume surges. I know in New York City, all the patients that did not get care for the last 18 months are back, and they are sicker because they haven't received care in the last 18 months. So we have a huge volume surge of non-COVID patients. Surgeries are back. All that is at full force on top of COVID. So we're dealing with that. Now we can add supply chain issues on top of that, because, we get a back order list every day of, how many things are not available because of supply chain issues. So it's a lot to deal with. Now, Connie, you talked about data. There's also data supporting everything I just said. So the American Organization for Nursing Leadership has been doing this kind of longitudinal study of leaders. They've done it 3 times since the pandemic began. The last one was August of this year. It's about 1,800 people in it. So we're talking about a very large group of national managers. And the biggest challenge, which in the beginning of the pandemic was PPE, is now staffing, is the staffing challenge, then the low morale of staff. And when asked to rate their own emotional health, 36% of those managers said, no, I do not have emotional health right now. A colleague of mine who did some courses with the New Mexico Organization of Nurse Leaders, they did like a survey monkey of the group there, and 64% of those managers said the current level of burnout is not sustainable, and they were kind of crushed under that weight. In Karen's Journal of Nursing Administration, there was a paper recently from authors in Virginia who interviewed nurse managers in 5 organizations there, and the themes were about moral distress, which, Cynda, I know is your favorite topic. And the reasons for the moral distress were not being able to manage the unit effectively, not being able to manage employee needs effectively. And on top of all of that, we have organizational directives. We have goals we have to meet. We have to meet patient experience goals and clinical goals and flow goals and efficiency goals. And all that has to be done on top of everything else that I just mentioned. So I think my very first #1 message is that leader well-being has to be addressed, and that they are as distressed as the frontline staff are. So my own research on authentic nurse leadership and healthy work environment and pandemic impact and intent to leave, I did a study last summer. 5,000 nurses from around the country responded to it. So this is last year. So it's old, but what it says from a year ago is illustrative of what's happening now even worse. So 1,000 of those were nurse managers and directors. We asked everybody to rate their pandemic impact on their practice on a scale of 0 to 10. And managers rated it 8.4 out of 10. That's pretty high. And that was a year ago. Frontline nurses, the other 4,000, rated a little lower, 7.6 out of 10, still huge. But what was really fascinating was 5,000 nurses, when they rated whether authentic leadership was present or not for them, the answer was yes, authentic leadership was present. And I think that shows the grit and persistence of nurse leaders through all of this. And I think that is an important part of us being able to move forward, is that authentic leadership or any relational leadership style that focuses on relationships with staff, each other, communication, transparency, honesty, leading with your values, caring. This kind of leadership will get us through this. But if we don't take care of the leaders, they're not going to be able to do it. So that's my message number 2, is that leadership absolutely matters. We also showed that it related to healthy work environment using the AACN model for healthy work environment. So I have now 2 studies showing that relationship. So authentic leadership helps in a healthy work environment. There are 5 other standards that have to be met. And if you are in a healthy work environment, you don't leave. So that 30–40% risk of turnover gets mitigated by authentic leadership. So that's another message. And then the last thing I want to mention, I mean, I could go on for the next hour, but Sean will start getting the hook out, is about care models as a potential solution for what we're in. We're in the staffing crisis. We don't have enough people. And there's so much talk about alternative models of care. We don't know what that looks like. We don't know exactly what that means. I think that it's happening already out of necessity, because we are working with less, and nurses are very innovative. So even on a shift by shift basis, you may redesign your care delivery model, but depending on what resource you have and who's available to help you. So the care models may be different for short term and for long term. I think that other disciplines may be involved in what the delivery of care model looks like. Like, what can other disciplines, how can they contribute and help us? During the peak COVID surges, we had functional teams to help out during that absolute unspeakable horror. And so there were proning teams, and this was by rehab therapists. We had airway teams, respiratory and anesthesia. We had a peritoneal dialysis team. Like, we had different functional teams to help people, and it wasn't necessarily all nursing or nursing at all. So there's probably ways to leverage that into the future as well. When it comes to like partnering and skill mix and changing that, I think, we know, and Connie, you mentioned this earlier, that the number of care hours, nursing care hours, matters in the outcomes of patients. So, and the skill mix matters in the outcomes of patients. So I think we have to be careful. And I think that the care models that we come up with, and I know the ANA is involved in this, there's a lot of people talking about this and wanting to figure this out. But in the end, we have to maximize top of license practice, because nurses doing work that could be done by others doesn't make sense at a time like this. And we have to maximize technology. I don't even know what that means, but in a practical way. But I think it's 2021, for God's sake. So I'm sure there are brilliant people that can figure that out. So my number 3 message is, we have to do this, and we have to be careful with it along the way. So I suspect my 10 minutes is up. Sean is shaking her head. So I'm going to leave. Anything else I have to say for Q&A? Back to you, Sean.
Thanks, Rosanne. That was great. And I just have to say, after Connie talked about 20 to 32% turnover and intent to leave, and then you mentioning a third of the managers having saying that they don't have moral health. Yeah, we really have a problem. So now I want to turn it over to Karen as a CNO and COO. what do you think what's your experience been, and what do you think might help as we think strategically about moving forward?
Thank you, and thanks for allowing me to be on the panel today. As regarding the CNO and my unique role for a lot of nurses now, I see in administrative roles that are non-nursing. I was also the chief operating officer. I feel like I'm seeing some emerging studies, particularly submitted to Jonah and some of the other journals, about the lived experience of clinical nurses during this pandemic. Less is being studied and published right now about the lived experience of the chief nurse. And I know on this seminar today, there are a lot of nursing students, there are a lot of nurse managers, there are some CNOs and hopefully some system CNOs, but I think we have yet to realize the extent of the pandemic related to the nurse executives as well. I know during the early parts of the pandemic, there were daily struggles and calls related to PPE supply, changing guidelines from the CDC where we had to right the ship, equipment shortages, staffing concerns related to not only nurses leaving to go to agency, but also just quarantine environment. Unpredictable census swings are a real disruptor for a hospital. You know, one day you think you have a particular census and you look at your surgery schedule, and the next day you have a large number of COVID patients that came to the emergency room. Patient disposition has become a national issue. And I know we have some international colleagues I've seen on the video from Canada and from other countries. You know, there are limitations to nursing homes and other places that could take patients that were either COVID survivors or sometimes were concerned about introducing new patients into a population. Families were very concerned about bringing post-COVID patients home, particularly early in the pandemic. And all those things created bed shortages in acute care hospital. From a nurse executive perspective, those things are also stressful. One of the things I always prided myself on as a nurse executive was being thoughtful in my approach to policies and guidelines and over communicating things to people so that I could make sure that they understood the rationale. In the case of the pandemic, that wasn't always possible. And a lot of times, instead of using what I would prefer, which would be more of a participative management style, I had to be hierarchical. I had to also do that, and I feel like other people had to do that on a unit level. Sometimes we had to make changes on PPE expectations with staff and had little time to explain that although two things were safe, you had to totally switch and do something else. And it was difficult. And it hurt also, I think, a little bit of the credibility between staff and management because staff started to not trust sometimes when directions would come down, whether something was for their benefit or because of a supply shortage. A thing that I think that we all need to look at, and I think this goes across all levels, and I would assume that it's also an issue with faculty in nursing as well. I think we need to challenge our financial models in HR. I feel like it is time. I've been a nurse 43 years. Many of the pay practices that we have in nursing right now were in place when I started nursing. I think that although we've been blessed that we have clinical advancement models and clinical ladders in place, we haven't used them necessarily to our advantage. And I think this is an opportunity now for us to go back and look at differentials and to look at pay practices and to really challenge some new models and see some research out there on things that are going to meet the need of the clinical nurse and the organization. You know, we have to really look at why many of our peers left to go travel. And was it all just about the money? And I think once we can answer some of those questions, we can try to look at nurse retention and satisfaction, because in my 43 years, I've seen periods where agency use is up and down, but not to the extent in this pandemic. And I really feel like we have to go back and look at why those nurses left secure jobs with a lot of benefits and what should we do differently in our HR systems and benefits to help retain them. One thing that I think is a big challenge for us is scheduling. And I know I've seen some studies recently published in Jonah, and nurses said scheduling has been a source of frustration and stress for them during the pandemic. I think that's a challenge for our IT colleagues and friends to go back and look at what are some new ways that we could help offer nurses more flexible scheduling models. And so I think that's something else that's an opportunity. My second area I wanted to talk about a little bit is a touchy subject with all nurses, I think, but it's staffing productivity. As a nurse executive, you're taxed with looking at productivity across large numbers of departments and in organizations. And it's something that oftentimes budgets are built by. But none of us now today really feel like that the acuities and the activities on night shift is any less than it is on day shift. That feeling that you can staff with less on nights was in place 40 years ago. And the patients were sleeping then, but now they're home. And the patients that we have in the hospital are sicker, the acuities are higher. And I think we really have to go back and challenge systems and organizations that have productivity systems in place that look at disincentives for shifts that are off shifts and weekends with less staff, because the acuities and the care are not less. I think the other thing we have to look at is we have to go back and look at the cost of living for our nurses. Yesterday, or in the last few days, there was a 5.9% cost of living adjustment for Social Security. I can't remember the last time that I saw a hospital do a 5.9% adjustment for pay. And I think we need to really look at a 1% and 2% isn't going to cut it anymore with nurse managers, with nurse executives, and with clinical nurses or other clinical staff. We have to keep up with the demands because we have daycare situations and other things that I think are going to be a challenge. So it leads me to my point with an organizational level. Is it time for organizations to go back and look at profit margin expectations? And do we need to really look at more investments in our staff than in capital? And I don't mean that buildings and equipment are not important, but staff is also important. And I think it's something that we need to look at from an organizational perspective. And that goes along with, I think, focusing on incentives and programs that can look at staff wellness as well as patient wellness, because we want to make sure that we have robust staff that can manage the stress and the unpredictable future that we know we're all going to face. My last challenge is, I will tell you, I feel like that we need to look at taking care of our leaders, because leaders also, as clinical staff, are suffering from PTSD and moral distress, as Cynda is going to talk about in a minute. And we want to not ignore the people in leadership positions and in other extended role positions. Many APRNs have been pulled into staffing jobs for things that they weren't suited for because they could fill a niche. And so overall, our profession needs a time of healing. I will challenge that I feel like it will take us several years to recover from this. We can recover and be better. This could be a good thing because we can learn to be more flexible. We've learned how to break down barriers. We can challenge existing systems. We can focus again on patients and outcomes. We can publish great work that can help others. But this is our time to take advantage of the benefits that we've seen from the pandemic and not just focus on the negatives. And I'll turn it over to Sean to introduce Cynda, because I think that she can talk a little bit about the moral recovery that we all need.
Karen, that was, I was watching the chats. People kept saying, right on target. I agree with everything Karen says. So you really hit some nerves there. And I think I really appreciate you turning it around to look at what we can do coming out of this. And I think that's one of the hopes that we were hoping today, is like talking about the issues, but getting them all out there to think about how we can move forward. I don't know how much I have to say to introduce Cynda, because everybody said, well, now Cynda's going to talk about this and Cynda's going to talk about that. But I will just say, Cynda, yes, Cynda is an ethicist, but Cynda spends a lot of her time over in the acute care system consulting with people on ethical issues and helping them cope with some of the issues they're seeing. She also led the Frontline Nurses Wiki Wisdom Forum, an initiative to bring forth the voices and recommendations of staff nurses to how to prevent what has happened in future pandemics. And AJN was happy to be a part of that. So Cynda, I'll turn it over to you.
Thank you, Sean. And of course, it's such a joy to be with my incredible colleagues, but also to be with fellow nurses as we sort of pause together to, really think about, okay, so what's next? And as I was listening, there were a couple things that I wanted to add to the sort of context. One is that no one is been through the last 2 years unscathed. And so every single one of us is carrying grief, all kinds of grief, whether it's the loss of people we love, neighbors, colleagues, people we never knew their name, people whose names we've known. And I think we have to acknowledge that grief is a part of the human experience. And it also influences the way that we are able to meet these challenges. So I want to start with that, because I think, we sort of think of ourselves as nurses, we're going to pull ourselves up by the bootstraps and we're going to meet these challenges. And we have. But there's been a cost. And I think what we've heard today is the cost has been fairly significant for everyone. And I really appreciate Karen and Rosanne and Connie talking about the both ends of the spectrum, because I've spent time with nurse leaders and with frontline nurses. And honestly, the issues track back, if you really were to peel it all down, to I cannot be the nurse that I want to be. And I think that when we feel that that image of ourselves as a good nurse, that we're not able to live our values of respect, of justice and fairness and equity and compassion for ourselves and others, it feels like a violation of something that is so core to us. And so what's been mentioned is this moral exhaustion that we have experienced. No matter what your role is, you've had to make hard decisions, whether it is the person in front of you deciding if you're going to allocate your time and attention to the dying person or the almost dying person or the one who's trying to live, versus being the person in the C-suite who's trying to figure out, how do I allocate staff in a way that reduces the likelihood of harm to the fewest number of people? Those are all ethical questions. And so because of that, what we're seeing in response to this is a real range of moral suffering. Some of it's moral stress, some of it is moral distress, where we feel like, this is a situation where I know what I should do, but I can't do it. But what we're seeing now is a more corrosive form of moral suffering, moral injury, which results when people engage in activities that violate their moral core, that begin to erode their sense of identity as a good person. And what is heartbreaking is when you hear nurses saying, am I still a good nurse? And you want to go, whoa, that sense of questioning that is a huge consequence. And so I think we have to be more precise in naming the sources of what is causing us to burn out, and to have a more accurate diagnosis so that we can design solutions that actually address the core problem. So we did some research, as we all do during this time. Connie mentioned we've been trying to find out what's going on. So we did a study of clinicians looking at the issues, organizational factors, moral injury symptoms, and moral resilience. Not surprisingly, what we found was that when organizations were less effective in their communication, in their resource availability, in the consistency with which policies were applied, when leaders were present or were not present, the symptoms of moral injury increased and the scores in moral resilience decreased. And so when we looked at the qualitative dimension of this survey, and we did an analysis, what we came to was the core issue was about broken trust. And so when you think about that, people experience broken trust as betrayal. And if you think about where trust was being broken, some of it was the perception of broken promises. I thought you were going to give me what I needed to do my job. I expected that I would be involved in decision-making. When there's ineffective communication, as Karen pointed out, it happened because things were changing so rapidly. When staff have reported being asked again and again and again to fill holes in the schedule on their off time, they began to interpret that as a disvaluing of their time and their boundaries. And so these kinds of betrayals accumulate. And one of the things an image is this death by 1,000 cuts, that it's not actually the big betrayals. Dennis and Michelle Reyna have done work on trust and betrayal in the workplace now for decades. And one of their findings in their work in other sectors is 90% of the behaviors that break trust in workplace relationships are small, subtle, and unintentional. The consequence, though, is exactly the same. The intention doesn't matter. The outcome of how you feel at the end of it is what leaves a person feeling betrayed. So I think we have to really explore how it is that we can acknowledge that trust has been broken, take responsibility for it, and begin to think about how do we rebuild that trust in communication, in our boundaries, in what we expect of each other, and how can we actually leverage the wisdom of the people at the front lines who are really experts at trying to figure out how to make systems work. So when Sean mentioned the Wiki Wisdom Forum, we asked nurses, what are your recommendations? And there were 3 things. The first one was protect us so that we can do our jobs. The second one was listen to us, and not just in a sort of passing way, but truly wholeheartedly listen to our fears, listen to our worries, listen to our solutions. And the third one was empower us, allow us to do what we do best. And so when you think about that, that is a little bit of a roadmap for how we might begin to restore trust at all levels in our healthcare system. It fits beautifully with the standards of a healthy work environment. It gives us a place to begin. And alongside that, I think there has also been an opportunity for us to think differently about how we allocate our scarce resource of humans. And Connie sort of mentioned this. I know I spent hours and hours developing algorithms for how to allocate ventilators and blood and medicines. I think we have to give as much time and attention and discernment into creating an ethical framework for the allocation of human resources. That could be our grounding for what we do in times of crisis and times in between. So I think I'm going to stop there. I would say that I spent yesterday with a group of frontline nurses. I did a retreat. And it's thrilling to me to just be with my colleagues. We went to a beautiful place, and we spent the day really acknowledging what everyone had carried. And one of the things that I was struck by was, first of all, the incredible commitment, the perseverance, and also the sense of judgment and guilt. Did I do enough? And I know leaders have asked that question again and again and again. And so I want to just say that as we think about these solutions, I think we have to reset our expectations at every level. We did not cause this. We cannot control it. And not one of us alone can fix it. So we have got to stand together and figure out the solutions on behalf of our profession, because if we don't, an external body of some sort will come in and provide solutions that I don't think we're going to want to live with.
Well, that sort of leaves me a little scary thinking that we're going to have somebody outside come in. The last time that happened, I remember, was back in the 80s when all these people came in and started downsizing and right-sizing and saying, here's what you need to do to deliver care, and here's who should be doing it, and you have too many of this type of people, and you need more of these. And that's exactly, I think, a really strong point to think about, is that we need to come up with the solutions that work for us, because we're the ones at the point of care that know it works. So, so thank you all for such great points and sharing your perspectives and your experiences. So now, Christine, what kind of questions do we get from our participants? And we have over 400 participants who are on right now. It's been fluctuating a little up and down, but we have 400 people who are still actively here, and I've seen lots of activity in the Q&A and chat. So Christine, do you want to throw some questions out?
Sure. First, I'll say there have been a lot of comments, and people have been very happy with the webinar and the speakers, and they're learning a lot, and a lot of energy and enthusiasm about some of the points that have been made, and they're very thankful to be a part of this. And so we have a few questions. Somebody would like to know, what strategies have you employed to address the ICU nursing shortage? So we can throw that to Rosanne. You're running a few hospitals. Do you have any advice on that?
I was afraid you'd throw that to me. This is challenging, and honestly, some of the things we're doing is trying to employ travel nurses, which is a double-edged sword, because as you heard from Connie, and I think it's even been in the chat a bit, is that how people are grateful for help, but working side by side with somebody that's making double the amount of money you are is really aggravating. So I'm kind of aggravated with the travel agencies, which I know is displaced anger because it's supply demand economics working, and but it just feels wrong to be demanding those kind of rates to get help into hospitals to take care of people. So that's just an opinion. There are, somebody mentioned that to give up your position to travel, you're giving up your benefits, your whatever tenure benefits you get, and schedule consistency, and knowing who your manager is and your team is. Like, you give up a lot to do that. So all right, I don't want to get stuck on travel nurses forever, but it's one of the things we're doing. The other things that we could do is look at how our budgets work. And I think, Karen, you talked about, what we've been doing hasn't worked, and we've had the same kind of models for 40 years. So I think that looking at how that works, what is the budget? Is the budget right? Is it right for the kinds of patients you have, or the numbers of patients you have? And when your skill mix is off, as was mentioned, if you have 80% new nurses, then that's not going to work. So you have to do something different there as well. So bringing in people who have retired to be resources on units and help the newer people, et cetera. Do you overhire so that this turnover, we're not waiting until somebody is gone before the position gets posted, and then it takes a while to onboard and train? Can we move that up so we don't have those gaps? So that's something else that we can do from an onboarding perspective. And then I know Karen wants to talk, but then there's like, who else can help us there? What other disciplines can help us in ICU so that takes some of the burden off of the nurse? Pharmacy, the therapy, respiratory therapists, like there are other disciplines that can help us. I'm going to throw it to Karen, whose hand is up.
Well, I'm going to look at it from a little bit of different perspective, because like I said, I think we're going to need several years to recover from this. And I think we need to re-examine some other systems too. And one of those would be our relationships with the schools of nursing. I think a lot of times early on, and really for the last 20 or 30 years, students' perceptions of different specialties in nursing have been based on their clinical rotations. And critical care is not the only area that's going to have shortages, or that is experiencing shortages right now. Emergency room, operating room, med surg, telemetry, it's across the board. And so I would like to suggest that I think as nurse leaders and nurse executives And nurses who are clinical nurses who work with students, we really need to start doing a better job of educating students early on in their programs about what exactly is involved with some of these areas of practice, so that as they rotate through there, they're not just focusing on the patients that they're caring for, but that they're focusing on the kind of nursing that those nurses are delivering. Because I think it will help them make more informed decisions as they start looking at their options for postgraduate work. I think the other thing is, and I don't have all the answers, I think we need to look at some creative ways to align students from early on in these programs into some of these areas so that they'll be more mentored longer before they graduate. Even though the residency programs have been great, they're not specifically focused on the areas of specialty. And I think we need to do something a little different related to preparing those nurses earlier on in the nursing education process for these specialties, including critical care, emergency room, and almost every other area.
And we have Cynda with her hand up.
So I wanted to pick up on Karen's point, and also one that's in the chat about preparing students to meet these challenges. So we are very fortunate to have funding to create a statewide initiative to look at how we can build resilience and ethical practice into pre-licensure programs and into nurse residency programs. What we found was that both of those areas are deficient in both pre-licensure programs and in nurse residency programs. It's like a module, you get one class. So what we are doing is we are working with 8 schools of nursing and 5 of our hospital partners to create a program for faculty to, first of all, come and be engaged in exploring those issues themselves, because what we know about education is that if the person delivering content is authentic in living it, being able to actually be resilient and to demonstrate what ethical practice looks like, students are going to benefit from that. So that's where we started in our first workshop. We're preparing now for our second workshop, and we have created a series of short practices that can be integrated into existing courses, so that it's not a one-off, but it starts on the first day of nursing school and goes throughout. We're also partnering with our nurse residency collaborative in our state to share these practices so students will have a kind of continuity into the work environment. What's been fascinating about it is that there's been a lot of energy around it and conversation about, Karen, to your point, how do we bridge the gap from, education into practice? So again, we use the crowdsourcing platform, and we invited students, nurses who were precepting students, to help us think about what's missing. And one of the big findings was students wanted real world experience. They don't want the theory, they don't want SimLab, they want to be in the trenches. Now, we all know how hard that is in terms of finding placements. However, maybe we need to think differently about that. The other thing they wanted was mentors from the first day of nursing school into practice. Now think about that. How many nurses have just transitioned into some other kind of role or out of nursing? Can't we harness that wisdom for our students and create a whole new cadre of support and resources to help them navigate these inevitable challenges and provide some incentives for that kind of engagement? So I think there are some opportunities that we really need to take seriously about how to, be more proactive and up, in the pipeline, so that not only are we adding more nurses to the workforce, but we're sustaining them and giving them the skills that allow them to stay in the profession over the long haul.
Connie, did you have something to add?
Yeah, I was going to say something else, but now I'm going to tag on to what Cynda just said, because I think you're right. Instead of a dyad of practice and education, I think there could be a triad of practice, education, and professional organizations. And an example that I would cite is we have a foundational course for critical care called ECHO, Essentials of Critical Care Orientation. And it sort of typically has been for when nurses are new to a hospital or new to a unit, they go through this online program and it's a blended learning thing, and they have clinical experiences as well as this. And we're currently trialing doing this with some senior nursing students in a couple of locations so that if they believe they want acute or critical care, they can pick and choose. I want to do renal, I want to do cardiovascular, whatever. They can pick and choose these things while still in their senior year, sort of the safety of that and the academic mindset of being in school, and come out already with a huge amount of knowledge when they enter the clinical environment. So we'll see how that works out. We're dabbling with it right now, but I think that could sort of be a perfect trio in a way, because there's a lot of professional organizations have a ton of educational resources, and we are really focusing at that novice level. So I would add that. The other thing, a totally different topic, but we were talking about it about 10 minutes ago. I recently became aware of, was doing a podcast interview of someone, and they were talking about this concept of stay interviews. And I don't know, Rosanne or Karen, if you all ever employed that. So what this person educated me about is it is leaders talking to staff, not necessarily about why are you leaving, but talking to your good, solid 15, 20-year nurses about why do you stay, or what would have you stay, and that kind of thing. I'm curious, do you guys have any experience and what your thoughts are about that?
Well, since you mentioned my name, actually, I just had a staff advisory board meeting, and they exactly asked me that question. Why are we should not be doing only exit interviews? We should be interviewing people who are staying and why they're staying. So I think you bring up a very good point, and I think that's something moving forward. That's a great idea. So I also, going back to something else we were talking about a few minutes ago, I just want to add, in the spirit of blowing things up, which has come up quite a bit when it comes to academic practice and now professional organizational partnerships. I'm just thinking the staffing shortage, we need help. Students want to learn how to practice. I feel like we should be able to, but the headwinds are so strong, to figure out a way to meld the old hospital-based learning model with the university model so that nursing students could be partners with real, like maybe it's a work school program like Northeastern or Northwestern, where you spend a year working as a student. And that would help the patients, it would help the nurse who you're partnering with, and it would ease the shortage, and you'd be a damn good nurse when you got out of school.
All right. So that was the first question, and we have about 18 more. So very good, very deep answers there. I want to throw the next one to Cynda. This is about violence in the workplace. So how do we deal with patients and their families who are bringing their anger and disbelief about COVID into the acute care setting? And this person has said, I've seen families yell at the staff and become physical with them. I recognize they're coming from a place of fear, but it is becoming extremely difficult dealing with this day after day. We used to feel appreciated by patients and families. The tide is shifting among the unvaccinated. What can we do?
Great question. I wish I had the golden answer for that, but I actually have been working with a group of CNOs and the Barrel Institute on this very question. And where we are at the moment is we actually created 7 ethical precepts to help guide us think about how we balance staff safety with the patient experience, because we don't want to overcompensate and take on a very rigid model that doesn't allow for us to discern what would be the right response. Now, that said, one of those ethical precepts is that no one, a patient or a family, should be exposed to situations where they feel threatened or harmed in their workplace. And so if we use these precepts to help us think about how do we do that in a way that upholds values like respect and equity and compassion, how would that help us think about possibilities for how to respond? So one of the challenges in our own profession is that nurses underreport these kinds of situations, and in part because we're very willing to dismiss them based on a person's, clinical situation. However, in other circumstances, those behaviors would never be tolerated. And so I think we have to begin to think about, what does respectful engagement look like? What are the expectations both of clinicians, but importantly of people who are in the hospital, either as a patient or as a family member? And what do we have in place that allow us to be able to be safe? Because if you're not safe at work, then patients can't be safe either. And so we've got to really think about, at all different levels, what does that look like? And how do we modulate and recognize our anger? The anger comes, it's energy that is reflective of values that are in some way threatened. And so if we can recognize that and then step back and ask ourselves, what would be the action I could take in this moment to restore respect and dignity for myself and for the person that is in front of me. And sometimes that means we need to exit from that experience in that moment so that we are not putting ourselves in harm's way. And I bet Karen has some more to add to that.
I do on this one. This is a hot topic for me. Jonah published an article in the last 18 months on the nurse as a second victim, and it was an article referring to a nurse involved with an adverse event and how the adverse event affected the nurse, even though the patient actually, was the patient that was the outcome of the event. And I took that article and looked at what was the true message related to violence in the workplace, related to the nurse as the victim. And there were several lessons learned in that. One is, you need to monitor and track it, or you don't even know how often it occurs. And when you start looking at it, you will be surprised where and when and what kind of events you even have. Two is that the employee involved in an event like that wants to be recognized. They want to know that people are aware that it happened to them, and they want to be acknowledged by their leader and other people that they're sorry that it happened. Employees often do not know how to access employee assistance or chaplains or peer support or other people, and making those available and teaching managers how to know how to help explain those resources to employees that are involved in an event are important. And the last two things is the employee wants to be part of the solution. They want to talk about what happened and what could have been put in place to help prevent it from happening in the future to anybody else. And the last thing is, you have to have a zero tolerance policy. You will get what you accept. And if you have a zero tolerance policy, you can keep your staff in the most safe level that you can.
I could just add
Great.
one more thing that is really from a policy perspective. In many states, the requirement for reporting violence or some kind of an event that involves harm to a nurse requires the nurse themselves to report to the authorities. And hospitals are not in the position to take on that reporting. Many nurses feel too threatened and too exposed to take that route. And as a result of that, the reporting is much less, and the responses that in other circumstances would probably end up in a legal process do not occur. And so one of the areas for our partnership is to work with our risk management colleagues to figure out, are there other pathways that would remove the individual nurse from the responsibility of reporting, and for the organization to take on that role so that they actually can find justice in that if it's possible, but not have to feel afraid themselves that they or their families might be at risk if they do report.
Okay.
I just want to say one thing. There is, having started my career in a large New York City emergency room at Bellevue Hospital, we were frequently, nurses were frequently involved in violent situations because of sometimes of the Friday evenings and, you know, all those things that we all know happen in terms of hot summer nights and gang wars and things like that. And one of the things that I remember as a young nurse feeling that helped me a lot and my colleagues was having an idea of what to do before the situation happened. So having practiced de-escalation techniques, knowing that if we entered a situation and we felt it wasn't right, or there was some, before it got to a full-blown violent or near violent situation, knowing not to let it get that far, immediately call a supervisor, call a manager, call someone else in before you get to that point. I just read that a hospital system in Branson, Missouri gave their staff, because they were having such a problem, gave their staff panic buttons. So they could, silent panic buttons that alerted somewhere else. This same hospital also, because most of their problems were having people, were with people being asked to put on masks as they entered the hospital. One of them, they had they hired dogs. They had security with just a, you know, big dog just sitting there. And they said very few people objected to the mask when they saw the dog. So they felt that really kind of de-escalated. So I think there are different things that we can look at how other places have implemented them to help nurses. But I think having a plan beforehand to know what to do as things progress is really helpful. Christine, I think we probably have time for one more question before we get to the questions, if we want to have the panel say something
Sure.
about the question that they would have burning in their head.
Absolutely. So this one, I'll throw it out to the group and you can raise your hand if you want to take it. As a staff nurse, you often feel that you don't have control over these larger issues of adjusting pay, changing staffing models, how to utilize resources, etc. What can staff nurses do at this time to start and inspire change?
Well, I'll start with that, and I'm sure others have some comments. It was said very early when we started, beginning to look within one's sphere of influence. You know, so I would say perhaps starting to look at, well, what can I do? And this actually gets to one of the important questions to ask that we're going to get to in a minute. But for example, what are the characteristics that have made us most successful in getting through this pandemic? And what can we do to keep those kinds of things present in our unit? But I think another element of the work environment standards that we've been talking about is this communication and collaboration. And I would encourage staff nurses, rather than coming from a place of there's nothing I can, you know, I'm just a staff nurse and nothing I can do. Try and engage in dialogue with your leaders. See what can happen. Authentic leaders like Rosanne and Karen and others, they want to know what's in the heads of staff nurses, and they oftentimes don't have time to come and sit with every single one. But I bet you if a nurse leader got a call from a nurse who said, I want to have a respectful, productive dialogue with you about what I see and so forth, they would clamor at the chance to do so. Coming forward with opinions about the reality of what's going on and also solutions. I think that is the other thing, is not just complaints and reporting on what's going on, but here's what I think we could do about it. And man, am I willing to work with you on this. And I've got a bunch of nurses back on the unit who I can enroll in working on this if you'll set us free or give us a leader to work with, that type of thing. It's a whole collaboration thing. We're here to help and work together.
So if I could just add a couple to what Connie just said. I would say that it's important for frontline nurses in particular to consider what is it that leaders need to know that would make it possible to sustain me in my role. And that means you've got to do a little human homework to answer that question for yourself. The answer is not out there. It's got to start first with really exploring for ourselves, what is it that's missing here? And how might I propose a way to fill that gap? I think another narrative is that no one's listening and nothing changes. So one question for as individuals is to say, what would need to happen for me to know that my contribution is valued? What would need to happen for me to know that I have been listened to and understood? So that it's not just an evaluation of did what I propose happen, because that isn't necessarily what listening will produce. And so it's getting clear in our own minds of what our expectations are by sharing this information. How can I clearly communicate what is at stake for me in my practice so that I can demonstrate why this is a problem? It's not just because of staffing in a large sense. It's because staffing is impairing the quality and safety of the care that I'm providing to the people that I am here to serve. That's a different message than saying there's not enough staff. So I really would encourage you to try to get precise about what is at stake and how can you be part of really creating the future.
I want to add on that and ask our leaders, Rosanne and Karen, there might be staff nurses out there who are intimidated to approach somebody in your kind of position. How would you like the staff to approach you?
I'll jump in. Staff approach me in every possible way, and it's all cool with me. I get personal emails, even dissertations at all times of the day and night sometimes. And sometimes I have to catch my breath and sleep on it before I even respond, but that's very powerful. I have my staff advisory boards. I have town halls. I'm rounding all the time. I want communicate. You can give feedback in a million different ways, and it's all good. Any way is good. And I would use what Cynda said about being more specific and not just being angry, and what Connie said about kind of using the appreciative inquiry approach, or the like, what can we do? And that's often a position I find myself in is, okay, you have to listen. As part of great leadership is listening, acknowledging what you're hearing, and then, okay, we have to solve this together. Like, what are your ideas? What can we do? And that's just very, very powerful. All of that, whether it's one-on-one, in a small group, in a big group, electronic, in person. There's many answers to that question, Christine.
Okay, great.
I was going to say, I would say I am an advocate that when you are running a hospital or when you're in charge of a bunch of departments, you have to look at it like a business, because it is a business. And so you can't have everything. I mean, it's your personal checkbook. You can't have everything, but you can move things around and you can ask for more. I think nurses need to learn a little bit more about the business language. And I think working together in a project team to look at experimenting with the new model and having some financial support to track the cost of that is a very powerful way to send a message. Because what you don't want to do is you don't want to just see that if you make these suggestions and they can't adopt all of them, you're not being heard. That's not always the case, but you have to demonstrate the value for the organization along with the outcomes, and that takes a process.
Okay, great.
These have been great questions, and I'm sorry we can't get to more of them. What I think we will do is try and get all these questions and look at them and perhaps almost do like a little qualitative analysis and see if we can maybe send out a blast email with some the questions and some thoughts on them at a later date. But we're just about out of time, and I want to part of the thing we didn't get to was to ask each panel member, you know, what burning question might you have? But I think we've kind of gotten to that because people have asked questions, Cynda and Karen and everybody, and certainly said, you know, here's some of the things that you need to think about and ask. So I think we've kind of covered that, and I don't want to beat a dead horse just because we said we would do that, because we had a great discussion. But is there anything anybody would like to say as we just end? It doesn't have to be a question, but just one thing you'd like to just put out there for all these people who have attended And certainly from the chats, we had somebody from Qatar who found this very valuable. So we've had a lot of great feedback. I think because people were being heard and people heard what you had to say in terms of approaching how we need to think about moving forward. So does anybody want to say a few final words to take us down the stretch? Rosanne, you have your hand up.
Well, I don't know if this is the final word or not, but I often take the Pollyanna role. And we lost Colin Powell this week, and I was reading his tips on leadership, 4-star general, US Secretary of State. And one of his tips was optimism is a force multiplier. And so I think we've all talked about many roads we can take to reshape ourselves moving forward based on what we've learned and what we're going through. And I'm so happy I'm part of this panel because I learned today as well. And I just think optimism is a force multiplier. And I don't want us to fall into the black hole. I would like us all 4 million nurses in the United States to help each other through this and to shape our future together.
Anyone else?
Yeah, this is Karen. I'd like to say I also appreciate being able to be on the panel. I feel like that this crisis has been an opportunity, and I think it's an opportunity to look at some of our sacred cows in nursing leadership, including pay practices and HR. And I think that's a positive, but I would suggest that people approach them methodically together and they publish and disseminate the results, because we all need to learn from each other. And as we all know, because a lot of us are editors, the best way that we can get the word out the quickest and the most far reaching is to disseminate your work through publications, through good peer reviewed journals. So I challenge you to do that.
Connie?
I would say take time to pause, whether it's in your unit, your department, your folks who come and support the CNO, whatever is your sphere, and look at what have we been through and who are we? Who were we when we started? Who are we now? And who do we want to be going forward? But take a minute. We're in such a busy world, and pause together to look at who we are and who we want to become.
Cynda, you get the final word.
Wow. I'm just thoughtful of the words of John Lewis, who talked about do not fall into despair. This is an issue not for this moment, for this day, this week, but for our lifetime. And we must all not only be optimistic, but hopeful. And hope is seeing things clearly, with clear eyes, not in a, sort of blind way, but to see it clearly and to choose to orient toward the possibility of what is out there for us. And in the process, to make good and necessary trouble. And so I hope that today is a catalyst for good trouble in our profession, and that we can use this moment to be in solidarity together to find the solutions, because this is not a time for division. We need to stand together and to take on this issue clear-eyed, courageously, and with intention. So that's what I got to say today.
Well, that's a great way to end. And I'm not going to muck it up by trying to say anything after that. I think you panelists have done such a fabulous job, and I so appreciate your taking the time out of your busy schedules to just join together and help us all think about how we need to go forward. To all of the attendees who I know are very busy in their own lives and work lives, thank you for attending, and I hope the program discussion, while not providing any clear answers, at least served to inspire some questions and understanding and a broader perspective as you go forward in your work and your challenges in your workplace. Just a reminder in terms of the CE instructions, stay on. They'll be appearing once we leave this, I don't know, go out into the cyberspace or whatever, once we leave this room. But to all my colleagues and friends and Christine, and I look forward to when we can all sit together and chat more about this in real life, in reality. So thank you. I can't thank you enough. This has been a wonderful discussion. And at this point, I'm going to hit the leave button, and all the attendees should be able to go to, or will be put in a place virtually for the CE instructions. Thanks again, everyone. Have a good night.